Bob, do you anticipate any changes with OASIS?
Yes, Doris. Most data sets tend to evolve over time to meet changing requirements, and OASIS will really be no exception. We'll probably have to make a few changes in 1999, for example, to accommodate the requirements of prospective payment. As we make those changes, we'll modify the Haven product, and we'll modify our training materials accordingly. And that's about it. I guess I just want to say we all have to remain flexible in the months ahead.
A good word.
Right.
Okay, thanks, Bob. Next, we're going to hear from some providers who have gone through implementing OASIS. That's right, that's what we're going to do. We're going to hear from providers. Bob, whatever you had is catching. And anyway, that's what we're going to do. So let's take a look.
Hello, I'm Kathy Chrysler, Co-Project Director of the Medicare Quality Assurance and Quality Improvement Demonstration. With me today are 3 representatives of agencies that are participating in the demonstration. These agencies have been collecting and transmitting OASIS data since early 1996. I'd like them to introduce themselves and tell us a little bit about their agency.
My name is Tracy White. I'm the Quality Improvement Coordinator at St. Mary's Home Care in Grand Junction, Colorado. We have about an annual census of around 1,100. We're located on the western slope of Colorado, and we serve primarily rural and an urban type of area.
I'm Sue Habiger. I'm Director of Regulatory Affairs with the Visiting Nurse Association in Kansas City, Missouri. We do about 150,000 visits a year.
Hi, I'm Donna Fallenfont. I'm Director of Clinical Management for Olston Health Services for the San Luis Obispo branch. We're a freestanding agency on the central coast of California.
Following from some of the points that Dr. Shaughnessy made about keeping the big picture of how OASIS relates to OBQI, tell me a little bit about the value of OASIS and OBQI to your agencies, keeping in mind both your patient care and sort of your overall quality improvement activities. Sue, would you start off?
Yes, we found that OASIS being such an objective assessment helped us in identifying the patients who needed to be recertified. That was very helpful for our staff. Also, we found that the objective evaluation of care provided that we did in our process of care evaluations helped us determine best practices and helped us focus on what we needed to do to improve our outcomes.
The beauty of the OASIS data collection tool is that it allowed nursing to assess a patient's overall functional status in their home setting, and it gave justification for incorporating other disciplines on the case. It promoted a more collaborative effort between disciplines in improving a patient's outcome. When we did see the overall outcomes as a result of the data that we collected, it gave us a really true picture of how patients are responding to home health care interventions.
I think it can be described in one word, and that one word would be invaluable. OASIS provides basically the basis for outcome-based quality improvement. Once you have all that information, you are able to focus your attention for what outcomes and what type of clinical outcomes really need some intense work to provide better patient care.
At the point that you received training in OASIS data collection, it was virtually an unknown concept. In fact, the data set had only been named OASIS a few months before you began. What was the first thing that you did after the training? What did you do when you went back to your agency?
I think the first thing we did was to eat chocolate and beg for mercy. After the initial shock wore off, we had to make a decision about our assessment forms, and we had to decide if we wanted to completely start from scratch or if we wanted to kind of cut and paste to include the OASIS data set. When we got to looking at our forms, we found that we had a lot of area for improvement within the entire form. What we did was essentially take an 8-page fill-in-the-blank type of assessment, incorporate our OASIS into our comprehensive assessment, and it developed into about a 17-page format. The nurses were real concerned with that number of pages, but it got into more of a checkbox type of format instead of a fill-in-the-box format. And we found after the learning curve happened and people were comfortable with the form, it actually shaved off about 30 minutes of our documentation time.
One thing we did was make a point of showing the staff what forms they would not have to complete. And we laid them all out, say, you don't have to do this one anymore, you don't have to do this one anymore, because that's all incorporated into OASIS. Because it is a lot of pages, and it is overwhelming a little bit to start with. We also asked a positive nurse, as opposed to a negative type personality, to complete several assessments using the new tool, which included OASIS, and then report to the staff when we did our training about what her experiences were with it and how she felt about it. We also had the supervisor of the team that was using OASIS and the instructor of the class complete OASIS on their own parents, so they would really have a good feel for what the nurses would have to go through and be able to give the nurses some tips. Another thing we did is we did some of our own computer programming to integrate OASIS into our current program to help facilitate getting reports and so on, and I think that was very useful also.
Our agency did pretty much the same. We integrated our own agency paperwork into the OASIS data collection tool. And then we asked 2 field RNs and 1 physical therapist to pilot this form for at least a month. And they said pretty much after 6 times, that was the magic number, that they felt very comfortable, that it flowed, it it wasn't as overwhelming, it wasn't as time consuming, it was very familiar and a very helpful tool in completing their assessments.
Can I ask whether when you did this integration, did you, and after people tried it out, did you come back and tweak it a little bit? Did you make some minor modifications, or did you get it all right the first time?
Actually, we're still tweaking.
Okay.
Our first assessment, we found a little bit of area that needed improvement, and as regulations changed, as some of the JACO standards changed, we also find a need to tweak and more tweak, I guess. It's a lot of refinement, and it's just, I would have thought by now we would have the perfect piece of paper, but we still don't.
Okay.
The interesting thing about OASIS, amazingly, is that it is not a complete assessment. That we did need to, and everyone else will find that they do need to have other assessment items that they're going to integrate with OASIS. And just this year, we decided that we did not have our pain assessment adequately presented to the nurses on the form, so we did some little sticky things on our form until we could get the forms reprinted. So it's an ongoing tool.
The tool is actually dynamic. I don't think it's ever going to be perfect. And every agency has different policies and different items that they have to include on an assessment besides the OASIS items. Everyone is given feedback from our branch about what they'd like to see changed, but once it was printed by our corporation, that's the way it stayed.
Since OASIS was so new when you implemented data collection, I think we should not sugarcoat all of this. You had to have encountered some resistance from your staff. Let's just accept that as a fact. How did you deal with this, and was it successful, and what tips would you pass on to other people?
We definitely were met with some resistance from all disciplines. Documentation is a big issue in home health, and they viewed it as being more time consuming and taken away from patient care. But it was not an option for our staff. We were committed as a branch to carry on with this program, so there was no option. They were required to do this paperwork. But we did do some positive things. We had a party in the branch to kind of kick off the implementation of OASIS. And there was ongoing instruction by our quality assurance manager, one-on-one, so as people had problems, they had somewhere to go, and they were able to get through it.
We found that we had resistance from individuals rather than the group as a whole. And what we did was let them express their frustration. We listened to them, tried to let them let it all out, and but then made it clear that it wasn't an option, that we were committed to this and we were going to go ahead with it. The other thing we tried to do was make OASIS or OBQI or this whole project as much fun as possible. And I think all of the agencies tried to do that too. We had a theme, and our theme was OASIS is the basis. And everywhere you saw an I in that theme, OASIS is the basis, we had a palm tree instead of an I. And we were able to find some swizzle sticks in the shape of a palm tree, and we gave those out as favors to everybody who was participating. We served food. We had lunch for our program, our training program, and we have found that food helps anything at the VNA. If we have food, everything goes better. We also offered continuing education credit for part of the training, the part that covered just the overall general view of what HCFA is doing and what this project is and what is an outcome and all of that kind of thing we gave continuing education credit for. And then the rest of it, when we got down to how you fill out the forms for our agency, did not give anybody credit. And that was an enticement to participate and come and listen.
Many agencies are surprised by the number of internal agency systems or processes that are impacted by the implementation of OASIS data collection. What did your agencies experience in this regard?
We experienced an impact in more areas of our agency than what we originally thought. We thought, of course, that there was going to be impact in medical records and the field staff and the quality area just because of OASIS. But when we really get into it for the long run and we start dealing with our outcomes management, we found impact basically in our entire agency, even in those areas that we didn't expect that OASIS would impact, such as in our accounts receivable or our billing department. Just because we're having to mail more and more forms to insurance companies, they want copies of all those notes, and the initial start of assessment is very lengthy with the OASIS questions. In order to manage this data, we also found that we really didn't need to add any additional staff. We found a lot of resources, a lot of shifting of job duties, and we created all of those resources within our agency to manage OASIS and OBQI. Probably about the biggest addition of resources is that our quality coordinator, or myself, I was only planning on working part-time. In order to manage all of this, I did have to move up to full-time, but we don't believe that OASIS was the sole impact. It was all of the other regulations and changes that are going on in the home care industry.
I would have to say that our medical records department was probably impacted the most by this program, basically due to the sheer volume of documentation that was coming through to their office. And they were trained to perform the data entry and also to check the tool and make sure that people had filled in every item. And it became very cumbersome. So we actually added an additional person to our department that would be designated solely to this program. That person would be responsible for tracking and entering all the data that came through the branch.
What can you share with others about the data entry, the data editing, and the data transmission aspects? What issues did this raise for you and your agency?
We went through a lot of trial and error for this specific process. The first thing that we started out with was that we had one person reviewing the documentation, making sure that all of the OASIS items were complete, that they made sense, and then it went on to our data entry for data submission or data entry. We then got this great idea that maybe one person could handle this entire thing, and we moved that into our data entry, that she could review all that documentation, decide if it needed to be sent back to the nurse or not, or if she could go ahead and enter that. That specific process was a nightmare. We got about 4 months behind in our data entry and data submission. From that point on, in order to get caught up, I was working till about 2 o'clock in the morning and then decided that it wasn't worth it. We needed to change this process. The current process that we have now is actually working very well. I'm reviewing the documentation for completeness, and then we have a process and some flow sheets that move on to data entry so that they know that all documents are ready for data entry and data transmission. We've also cross-trained all of our medical records personnel to enter some of that data entry so that it doesn't get behind again.
I think, Donna, you said something different about your agency, about whether you needed additional staff.
Ultimately, we did decide to add an additional person that would be designated to entering the data, doing the edit, and also responsible for the transmission. But medical records is definitely a backup. They are trained also, so that if that person is out, the process continues, because it's important to keep current. Our clinical managers review documentation up front also, so we can catch it there before it even goes to the data entry person. So there's very little for her to follow up on. She can actually just enter the data.
We found that we had to purchase a PC. We had a mainframe we weren't capable of transmitting and so on. So we had to purchase a PC. We also dedicated a data entry operator to this particular function, dealing with OASIS and the transmission and so on. And we also noticed at one point we had a quality problem, data quality problem, which resulted from our NCR paper not lining up well, and what the nurse thought she had circled, the data entry operator chose something, or entered something else. So we had to really watch the NCR paper.
If you were starting now, what would you do differently? Think about this maybe as being advice for other agencies. What would you change?
If we were beginning today, there were two things I'd like to do differently. One would be that we would incorporate the referral, the intake referral, into the OASIS assessment form, and I would like to see it generate a plan of treatment. I think that would streamline many processes within our branch. The other thing is that we would definitely have a specific process in place for accepting the data, reviewing it, tracking it, entering it, and transmitting the data. The form itself is easily learned. Documentation changes all the time. This form will change. The staff adapt to it and they can learn that easily, but the process within the office has to be intact. That needs to be set up before you get started.
That's a good point, Donna, thanks.
We would start education and training sooner, and at all costs we would avoid the Christmas holiday time. We would get more staff involved in developing the form and in giving the classes, training other staff. We did a little bit of that, but we would do that even more so if we had it to do over again. We would work at all costs to avoid duplication. As you were saying, the plan of treatment and some OASIS items are duplicative. We would work harder to keep up the momentum and the enthusiasm than we did the first time. We would, as some of the agencies did, have newsletters, have special reports, special bulletin boards or something like that to keep up the momentum and the enthusiasm.
I wish we would have had this knowledge from day one. I think probably the one thing that if I could have done differently I would have been to incorporate larger teams from the very beginning. We had basically 2 nurses that developed the entire assessment forms and incorporation of OASIS, and that might have produced some of the resistance that we also saw within our agency when it came to training and getting the field staff to support this entire process. I think a team of 5 would be very good if we had the quality coordinator there, a physical therapist, and about 3 field staff of varying specialties. That might have helped support the entire OASIS project and outcome-based quality improvement project.
Thanks, Tracy. Did each of your agencies have a coordinator who led the implementation effort? And do you think that was good? Do you think a coordinator is an essential component? Who's a good candidate for that coordinator position?
Absolutely. I think the person who is in charge of managing quality is a good person. In our case, I was the coordinator along with one of the clinical supervisors. We worked together very closely to make this whole thing work out.
Our branch originally began this project with an actual quality assurance manager, but unfortunately that position was eliminated and delegated to me. But I didn't find it as cumbersome because I had such a good multidisciplinary project team that was very helpful in our process of care investigation and our monitoring activities. So it can be delegated to someone in administrative staff, but it can also be delegated to somebody from the field with a quality assurance interest.
I believe it is important to have one person leading an OASIS OBQI implementation, but the team concept is also very useful. You can get people from different disciplines, different knowledge fields, and different perceptions in order to develop really good processes that work.
I'd certainly like to thank the three of you for participating today. I think this has been an excellent opportunity to share some of your experiences with other people who are just beginning the process. I think that, again, I want to remind us all that we're looking at the big picture, that we're not looking at simply a set of data items, but we're really looking at patient outcomes and how patient outcomes can be used in our agencies to monitor quality and to improve quality over time. That OASIS is helpful as part of a comprehensive assessment, but it also helps us to look at what it is that we're doing, what impact care is having on our patients, and then we can begin to move forward from there. So thank you again for coming.
Kathy, does an assessment with OASIS items require the clinician to collect a lot of new or different information?
No, Doris, the information is part of any agency's assessment information right now. The only thing that OASIS means that's different is that there is a lot more specificity to the items, so that agencies will need to be sure that their clinicians are prepared for the increased specificity of the assessment needed to answer the items.
All right, thank you, Kathy. Now, as you can see, we now have been joined by new panel members, so let me introduce them to you. Mary St. Pierre, Director, Regulatory Affairs for the National Association of Home Care. Janice Stevenson, Health Insurance Specialist, Clinical Standards Group, Office of Clinical Standards and Quality. And we have Tracy Mummert, Health Insurance Specialist, Continuing Care Providers Branch, Center for Medicaid and State Operations. Now, our next presentation by Mary St. Pierre will include discussions on how a home health agency should prepare for OASIS. Her presentation will include startup strategies, comprehensive teams, and establishment of goals and timelines.
How should home health agencies approach implementation of OASIS? Implementation of OASIS in a home health agency must be a team endeavor that is approached systematically. The first steps in this endeavor include establishment of a team with administrative, clinical, and clerical representation, and establishment of goals and timelines. Administrative representatives will bring information about the agency's mission, resources, and budget to the effort. Clinical members should be individuals who are adept in patient assessment and who can provide insight into the essential components of a good clinical assessment tool. Skilled clerical personnel are critical for the efficient documentation of proceedings and form changes and development of new forms. Agencies that employ information systems personnel should include a representative from this area as well to assist with data collection and reporting aspects of OASIS implementation. Before embarking on adoption of OASIS, each agency must determine the financial and personnel resources available for this undertaking. This information is critical for basic decisions, such as whether to incorporate OASIS into the agency's current assessment or to purchase a commercially available assessment in which OASIS has been integrated, whether to hire personnel for data entry or to contract with an outside service. Once budgetary resources and limitations are identified, a strategic plan defining goals and target dates must be established. The plan should address all aspects of regulatory requirements to ensure that your agency will be in compliance with OASIS data collection, recording, and reporting requirements. The plan must encompass implementation strategies and staff training. After the team is identified, scheduled work sessions should begin and specific timelines identified for each phase of the project. It is essential that every session be goal-oriented to ensure that the final products, a comprehensive assessment tool with OASIS data items, and a plan for OASIS data reporting are completed in time to meet the implementation dates required by the regulations. Once your agency has completed work on adopting an OASIS assessment format, it must be pilot tested. Pilot testing is critical to ensure that the tool is right for your agency. The tool must not result in documentation burden, must be comprehensive, and must be an effective assessment tool for your agency's patient population. If the need for change is identified, modifications need to be made before finalizing the form and training personnel. When final modifications have been completed, forms can be printed. When making decisions about printing options, consideration should be given to future modifications that may be required to the OASIS data items once the PPS case mix demonstration project is completed next year. Staff training is the most important activity in implementation of OASIS. Training should actually be started at the time the OASIS team is established. All staff should be informed as to why OASIS must be adopted in your agency. They should be informed of regulatory requirements and the role and benefits of OASIS in patient care and ways to improve patient and agency outcomes. Staff should be kept informed of progress as the tool is being developed. Once the comprehensive assessment tool with OASIS has been developed, tested, and modified, formal training sessions should be planned for all clinical staff. Training will require, at a minimum, one 4-hour comprehensive program with a shorter session at a later date to address problems and questions. Some clinical staff may need individual follow-up if problems are identified.
Well, Mary, where can an agency purchase patient assessment tools that meet the OASIS requirement?
Doris, in addition to OASIS being available on the HCFA website and eventually the electronic version of OASIS in the form of Haven, there are a number of vendors that actually sell the OASIS tool, and we anticipate once electronic specifications are completed that they will also have the electronic versions.
All right, thank you, Mary. Well, is the OASIS data set intended to be a complete comprehensive assessment? That's a question that will be discussed by our next presenter.
Home health agencies are required to integrate the OASIS dataset into its own assessment process. For clarity, the OASIS dataset is not intended to constitute a complete comprehensive assessment. Rather, incorporation of the core standard assessment dataset will complement the home health agency's current approach to comprehensive assessment. All OASIS data items were developed for outcome measurement, risk adjustment, or patient identifiers. OASIS data items address demographics and patient history, living arrangements, supportive assistance, sensory status, integumentary status, respiratory status, elimination status, neuro, emotional, behavioral status, activities of daily living, medications, equipment management, emergent care, and discharge information. The OASIS data set does not include an assessment of vital signs, which are a common part of a patient's assessment. For this reason, home health agencies must integrate the OASIS items to comprehensively assess the health status and care needs of patients. Most OASIS items require the same information that the majority of care providers currently gather in patient assessments, but the OASIS requires the information on a more precise scale. For example, many care providers assess each patient's ability to bathe using only 3 levels. OASIS uses greater precision, which results in items that are more descriptive for clinical purposes and items that are more reliable and valid. This statistically improves their utility in an outcomes database environment. In this way, all approved agencies will be collecting information using precisely the same items to ultimately measure and risk adjust outcomes. To incorporate the OASIS data set, the agency should review its current clinical documentation and compare assessment items with similar OASIS data items. Next, the agency would determine whether to adapt its current form using a cut and paste approach or develop an entirely new form. Home Health Agency assessment items plus OASIS items equal the integrated assessment. For example, under the activities of daily living, in assessing a patient's ability to bathe, an agency may note only the following 3 levels: independent, needs moderate assistance, or dependent. The OASIS data set evaluates a patient's ability to bathe on a more precise 6-level scale. This information is provided in your packet. In this example, all of the Home Health Agency's assessment questions are indicated in the OASIS. By replacing the more precise OASIS data item MO670 on bathing for its assessment, the agency may eliminate its assessment questions in this area altogether. In many instances, all of the Home Health Agency's assessment items will be replaced by OASIS data items. This results in a more streamlined assessment.
Janice, in your presentation, you talked about integrating OASIS. How must the OASIS be integrated?
The OASIS can be integrated within the agency's own assessment in any order to meet the individual needs of the agency. However, we don't recommend it because of the skip patterns within the groupings. It could decrease the efficiency of the encoding process.
Okay, thank you. Our last presentation will answer questions on how a home health agency should approach implementing OASIS and data collection. But before we hear that presentation, let me remind our viewers to complete the participant reaction sheet in the back of your handout package and then turn them into your site coordinator. The site coordinator should fax the participant reaction sheets and/or the final downlink information sheet to Barbara Massenberg, and here's the fax number, area code 410-786-1008. Now, following the session, we'll also have a 15-minute phone-in session. The number for calling in your questions is 1-800-953-2233. And the fax number, if you're too shy to call, you can fax. The number is 410-786-1424. Now let's return to our next presentation.
Let's review what you will need for OASIS data collection and reporting. If you already have a computer system in your home health agency, you may have already made a mental assessment of how it stacks up to the requirements that Bob Goldrick mentioned earlier. If you do not already have a computer system, or simply wish to upgrade your existing system to one that will more efficiently report OASIS data, we recommend that you consider using the following configuration shown here on the screen. We recommend a Pentium processor with Windows 95 or Windows NT, with 32 megabytes of RAM, a 2 gigabyte hard drive, a CD-ROM drive, and a fast modem. We recommend a 56 kbps modem. We also recommend a color monitor, access to the internet, web browser software, and last but not least, a printer. This is a review of what you were shown before as a recommended computer configuration. Bear in mind that a system with less capacity than the one recommended may work, but it may not work as efficiently as you would like. All home health agencies should have a computer with a modem for electronically transmitting OASIS data, as well as a web browser like Netscape, which provides the home health agency with the necessary functions to transmit OASIS data to the state. You should also have internet access if you want to be able to download information from the HCFA website. As an option, a home health agency may wish to contract with a data entry service that will take care of data entering and reporting OASIS information. This is perfectly acceptable, but remember, the home health agency is still ultimately responsible for meeting the reporting requirements as well as maintaining patient confidentiality. If you decide to contract with a data entry service, be sure to address confidentiality of patient information in your contract. With regard to software, home health agencies have the option of developing their own or purchasing data collection software that can be used to support the OASIS reporting requirements, as well as other clinical or operational needs such as care planning, quality assurance, or billing. However, as mentioned earlier, HCFA is developing software to accommodate OASIS data entry and transmission, called Haven. Haven will be available for downloading off of the HCFA website at no charge. In lieu of downloading the Haven software, HCFA also plans to make a CD-ROM version available. If you plan to use the Haven software, remember, you will need to have internet access or a computer with a CD-ROM drive in order to obtain and install the software on your system. We expect Haven to be available for general use sometime in the fall. Haven will allow you to collect OASIS assessments in a database and transmit those assessments in a standard format to the state. Software vendors are welcome to use Haven as a core program for developing their own software that supports the OASIS reporting requirement, while also supporting other agency needs. We realize that home health agency staff will require training on encoding, which means entering OASIS data into the computer, and compiling OASIS data for electronic submission to the state. At least one person in each home health agency should be trained in data entry and data transmission procedures. We expect that the state will provide training to familiarize home health agencies with the steps for startup, initial transmissions, phone numbers, passwords, the Haven software, and feedback reports. HCFA is currently in the process of training the states for this function. Home health agencies have flexibility in choosing a method to encode their OASIS data, but that method must comply with requirements for safeguarding the confidentiality of patient records. For instance, after it's collected, data can be entered directly by a clinical staff member using a laptop computer or by a technical or clerical staff member from a paper document, as long as it's been completed by a clinical staff member, or by a data entry operator under contract to the home health agency to key in OASIS data as mentioned before. Finally, on at least a monthly basis, agencies must transmit all their OASIS data sets completed in the previous month to the state. You are invited to do this more often, but monthly is the minimum requirement. The regulations on collection and reporting of OASIS data will provide you with additional written information on the topics presented here today when they are published. In addition, home health agencies will have lots of access to help in implementing OASIS requirements through such things as telephone hotlines, detailed instruction manuals, state and HCFA personnel, and don't forget our HCFA website. Let's take a look at that address again. Thank you for taking the time today to familiarize yourself with the OASIS project.
Tracy, you mentioned that if home health agencies contract with a data entry service for data entering and reporting OASIS information, to make sure they address the patient confidentiality in the contract. What did you mean by that?
Thanks, Doris. Under the new regulations, when they're published, home health agencies and their contractors will need to maintain confidentiality of the patient's medical record. That means that OASIS information should not be released if it's patient identifiable for any reason other than for what it was intended. If a home health agency chooses to contract with a data entry service, which they certainly can, the contractor must also maintain that same patient confidentiality. In the contract between the home health agency and the contractor, there should be some language that speaks to this confidentiality issue. Thanks,
Tracy. Before we conclude today's broadcast, we'd like to provide you with a final opportunity to call in or fax in your questions. The telephone number is 1-800-953-2233, and the fax is 410-786-1424. And as we mentioned, if you have any questions that you didn't get a chance to ask earlier, this would be an opportunity to get those questions answered. Janice, let me ask you this. What if my agency's assessment in an area has more items or asks more questions that are on the OASIS?
Doris, if that's the case, the agency should do a side-by-side comparison, and any items that appear on the agency's assessment that also appear on the OASIS, the agency should delete their own items and replace them with the OASIS items.
Thanks. Let's take a telephone call now. We have Melinda on the line. She's calling from Fort Lauderdale. Please go ahead, Melinda. Let me say one thing to any of you calling in. Make sure you turn down the volume on your set so we don't get a lot of feedback. Go ahead, Melinda.
Okay, question. Has HCSA received any information from Joint Commission on using OASIS to meet the OREX requirements?
Okay. We're going to step over to the microphone.
This is Mary Vienna. As some of you may know, the OASIS data set, those data items are acceptable to the Joint Commission for purposes of meeting the OREX requirements.
Thank you. We have a group of 50 here, so I have a couple more questions.
Okay.
How will OASIS data set be updated and transmitted with each new diagnosis in a given bill month? For example, if a start of care is 1 month with one diagnosis, then 10 days later there's a new diagnosis, and then 10 days later is an additional diagnosis.
Is that a Mary Vienna question again?
Sure.
Okay, just stand there, Mary.
The collection of the OASIS information is tied to the length of time the patient's being seen by the home health agency, not the diagnosis. So that if you had a start of care date and the patient had diabetes, and they developed a stroke during the time, a mini stroke during the time they were being seen by the agency, you would not restart the clock for the OASIS based on that new diagnosis. You might collect the OASIS information because it's a significant change in the patient's status, but it does not have to be collected every time the patient has a new diagnosis.
Have there been any criteria developed to adjust the payment levels for PPS?
Does that, Bob Wardwell? Step up to the mic.
Well, because the system is really just under development at the present time, it's a little bit premature to talk about the criteria. All the OASIS items that currently exist, plus the OASIS Plus items, are being utilized even as we speak by research agencies. The results of that should be coming out within the next few months, at least in a preliminary form. At that time, we'll have our first inkling in terms of what items will be correlated with enough resources to predict utilization, and by predicting utilization, we're able to adjust rates accordingly.
Okay. Any more questions, Melinda?
If you have a Medicare certified agency that's servicing all payer sources, is HCSA going to require all OASIS information on all patients?
Mary Vienna, back to the microphone. Or Janice?
I'm sorry.
Okay.
Took her off guard. The home health conditions of participation apply to all patients served by the agency. So we would expect that OASIS be collected on all patients with the exceptions that I mentioned previously.
Okay. Any more questions, Melinda? Let's take another call from Margot, who's calling from Maryland, and I just want to let you know we have extended the time of our broadcast until 4 p.m. Eastern Standard Time. So you'll have plenty of time to get your questions answered. Janice, if we add the OASIS items to the assessment, won't the OASIS make an agency's assessment process long and drawn out?
Yes, it will. That's the reason we say that in doing a side-by-side, looking at their own assessment items, looking at the OASIS items, the items are integrated, and the agency would replace their own assessment items with the OASIS items. That's what makes the assessment integrated.
Okay. Let's take another telephone call. We have Betty from Tennessee calling. Please go ahead, Betty.
Hello?
Hi, is this Betty?
Yes. I have a question again regarding the patient population that is affected by OASIS. if a home health agency owns a home infusion therapy division and a private duty division that provides home health or not home personal care support services and private duty nursing in the home, would those patients also have to have OASIS collected on them?
The conditions of participation apply to the Medicare certified home health agency. So if the agency had another company providing DME or other kinds of lines of business, the OASIS requirement would not apply to them. As a matter of fact, it would be inappropriate to collect OASIS information for a large subset of populations. Another example mentioned previously was hospices. If a home health agency has a hospice, OASIS would not apply to those patients either.
All right. Thank you, Michelle, for your call. Let's take our next call from Nate, who's calling from Baltimore.
Yes, I have a question regarding the interaction between OASIS and reimbursement rates, specifically regarding possibility of OASIS creep in HHA, similar to what we experienced in the DRG creep in hospitals. What's the plan to prevent this?
Bob?
I think it's a fair assumption, too, that there may be some OASIS creep, just as there's been DRG creep in hospitals. There's no real way that you can hope to prevent it. I think that the best thing you can do is hope to adjust to it. The PPS system that we come out with, October 1st, 1999, is not going to be the prospective payment system for all time. I'm sure that this is going to be a work in progress, and these weights will have to be adjusted with time if, in fact, we do experience a creep.
Okay.
Okay, I have a question from someone else in the audience here. Hold
Go
on,
ahead,
please.
Nate.
Hi, this is Karen from Maryland. Can Haven produce reports?
Bob Goldberg?
Yes, that question was raised earlier too, so I'll address that. Yes, Haven can, and it depends on the type of report. When a batch or file is submitted to the state system, you'll get an immediate report on what's been accepted, what's been rejected with what we call a fatal error, and what's been accepted but has some problems, and those will be identified. Haven will also produce certain pre-programmed reports that'll give you like patient rosters and reports on the assessments submitted to the system. Eventually, when we get enough data, 6 months or a year's worth of data, Haven will also produce quality indicator reports, and you can access those. Someone earlier asked when would they be available. The ones on the batches you'll get immediately. The others are available on demand. You can just log on to the state system and get them at that time.
I guess I'm asking about reports that analyze the data and can be used for quality improvement.
The quality indicator types of reports?
Yes.
Yes, those are the ones that Haven will produce, but you won't get them out of the very first batch of Haven. Haven is basically a data entry tool. It's the state system, and maybe I should have been clearer about that, that will produce the reports and that you will get via logging on to the state system. Haven itself will maintain a database within your agency that you can look at, but it doesn't have built-in reports of the quality indicator type.
I have one more question.
Go ahead.
The software companies are, I guess, besieging us with information and offering all kinds of great things. One of the things they're talking about is scanning the OASIS form instead of having a data entry person. Can you respond to that?
Well, that's a capability that's out there. Again, we talked about Haven in terms of one alternative. I think what you want to do is have those people in, evaluate what they're doing. Don't sign any contracts until you've seen a test of what they're doing and make sure it meets your needs. There are lots of capabilities and lots of vendors that'll be in this business. But you want to make sure that they're meeting your needs.
Karen?
We have one more question here from the room. This is Linda from Baltimore. I have a question for Tracy regarding Medicaid. I think Mary Vienna had mentioned before that there are situations where Medicaid-only agencies might be excluded because of waivers. It's a two-part question. First of all, the Medicaid data that will be collected from some of the agencies,
will the same type of analyses be performed for them? And secondly, is there any communication encouraging the Medicaid agencies to participate voluntarily?
Tracy?
I don't think I have an answer for that.
Does anybody have an answer?
Anybody from our distinguished panel?
Well, you know what? We may not have an answer right now, but when you put that up on the website, put that question up, you'll get your answer. Okay, Linda?
I have one more question. This is Jenny from the Maryland site. We're passing the phone around here.
All right.
I wondered if there has been a date set yet for the final regulations to be released. There's been a lot of talk about when they might be coming out, and I know originally they were scheduled for June or July, so I'm wondering if that time frame has been set.
Okay, Mary?
It's difficult prognosticating when a regulation is going to come out, since there's multiple levels of review of a regulation. All I can say is that we expect the regulation to be published shortly.
Okay.
All right. Thank you, all of you from Baltimore. We have Susan on the line from Florida. Thank you for waiting, Susan. Please go ahead with your question.
Thank you. We have 3 questions, and the first question is for Bob.
Okay. Which one?
And the question is, on the HCFA website, it says that we can download the files from Adobe Acrobat, the PDF format. Is that available in any other word processing format?
Bob Goldrick.
Hello?
Yeah, hold on just a second.
We were deciding which Bob that was. It's this Bob, and I think the answer is no. That's the only way they're available right now. I think maybe while I'm up here, I should mention one thing that someone asked earlier, which is when will Haven be available? Might be good to mention it now. And the version that we'll put out on the HCFA website will be available October 31st. If an agency were to request a CD-ROM version of it, it won't be available for a week or 2 after that because it takes time to press the CDs and mail them.
Okay.
Okay, thank you. We have a couple more questions.
All right. Go ahead.
Hi, this is Susan, also from Florida. Do you have to complete a resumption of care for patients who go into the hospital for a 23-hour stay or for an outpatient procedure?
Okay, Mary Weekland?
Okay, if a patient goes in the hospital and is going to be in the hospital for 24 hours or more, you'll need to complete a resumption of care stay. Only if that stay was for non-laboratory testing, diagnostic testing.
Okay, Florida?
Okay, thank you.
Do you have
also, when there are multiple disciplines on a case, do all the disciplines have to complete the assessment upon resumption of care or at discharge, or who is primarily responsible for that?
Okay.
Go ahead.
Okay. Typically you have more nurses in a home health agency than other specialty types, so the nurse can complete that. You don't need to have all the different disciplines complete parts of it, although you could do that if you chose to. You could have one person do that.
All right.
Okay, thank you.
All right, and
I just
Kathy?
wanted, Doris,
Go
I
ahead.
wanted to add to that from the standpoint, I think it's important to realize that what you are going to be receiving is a report that talks about the outcomes of care for your agency. Think about that patient as a patient of the agency, and therefore you need to look at start of care and at 60-day intervals and at discharge from your agency. So whoever is providing care, I think it's important to say, this is my agency's patients, and I'm going to look at data collection, comprehensive assessment, and OASIS data collection as it reflects what the patient's status is in my agency.
Okay, thank you, Kathy. And thank you all from Florida. Let's take a call now from Cleveland. It's Michelle on the line.
It's obvious that implementation of OASIS is labor intensive, even with a minimalist mentality. Can anyone tell us if there's going to be any reimbursement or financial compensation for the effort?
Okay, turn down your volume, Michelle.
Okay. Okay.
Bob Wardwell?
Okay.
We're getting you an answer.
Hi, OASIS costs are, within reason, are allowable costs on your cost report. So in the context of cost reimbursement, there is not an issue with it being an allowable cost. Of course, the difficulty is that under the current cost limits, many agencies are at their cost limits, and because they're at the cost limits, even though the costs are allowable, they may not be recognized. In the regulation that we just published this month on the 11th, we indicated with regard to the per visit limits, we have some flexibility. There's an allowance in there for some additional cost for OASIS collection. We also ask for comments regarding other kinds of costs that agencies will be experiencing, particularly real data on what costs they'll experience in OASIS, with the idea that in responding to those comments, there might be a way to raise the limit more if there are actually more costs that agencies will be experiencing. The frustrating part of this, of course, is we're talking only in terms of raising the limits with regard to per visit limits. The per beneficiary limit, which in many cases is viewed as more stringent, is so set in the statute as an absolute amount of money, an absolute base year amount, that we don't have flexibility under the current law to change that. There's certainly some interest, I understand, in Congress, not only in changing the interim payment system, but in terms of perhaps changing the formula to allow that limit to be raised to accommodate some OASIS cost. We'll just have to wait and see on that one.
Tracy, let me ask you this question. Mary Vienna mentioned using OASIS in a chronological order, but didn't say if it will be required or not. The OASIS webpage says it will not. Is this still true?
That's a question that's been popular in the past few months, and I guess the old adage, if we knew then what we know now, would apply. We have gone back and forth with this issue. Now that we've had a chance to look at at least the initial phases of the Haven software, we realized that it wasn't necessary to require home health agencies to incorporate the OASIS data items in sequential order as they're presented on the form. However, let me just say that we don't recommend that you put them in out of order. It may slow down the process of actually entering that data into the Haven system.
Okay, thank you, Tracy. Let's take a telephone call quickly. We have Ms. Rose, I guess, from Minnesota calling.
Yes, I'm here.
Hi, go ahead.
I have 5 questions. The first one, if an agency provides services in 2 states, will they have to submit the data to 1 or 2 states?
Okay, if that's the first question, who's going to take that?
I'll take it.
Go ahead.
Okay, if an agency has branches in 2 states, the branch will be needing to send the data to the parent agency, who will send it to the state where they have their license, to the one state.
Okay, so you'll send it to the state that you have your license in?
Yes.
Okay. What if you're licensed in both states? You're housed in one state, but licensed in both states?
I think I'm going to have to get some clarification from my panel of experts, and we'll have this on the webpage.
Okay, thank you. The second question, can state home health associations send representatives to the HCFA-sponsored educational sessions?
I'll take that.
Mm-hmm. Go ahead.
Do you want to take that?
Actually, I'd be glad to take that. The plan right now, HCFA is sponsoring an educational training program, and it is in 2 phases. Phase 1 is the end of August and the beginning of September. At that phase, the training will be only for state surveyors. After that, there'll be phase 2, and phase 2 will be held in October. HCFA has invited the state associations to designate a representative for their states to participate in that training in October. And we do have some dates for that, and we will make those dates available, hopefully by the end of today, to the state associations.
Okay. Any more questions?
The third question, what are the timelines for completing the discharge data set?
Good question. I'll
Go
take
ahead,
that.
Mary.
The discharge data set is going to be, it will need to be complete within 48 hours after knowledge of the discharge date.
Thank you. The fourth question, Mary earlier in the conference encouraged agencies to pilot their new forms. After the final rule, will agencies be able to collect OASIS on only a pilot group of clients versus their entire Medicare certified population?
I'd suggest you start doing your piloting piloting sooner than after the reg is published. Once the reg is published, there will be some effective dates, and those dates won't be available for piloting testing. So you might want to think about doing your testing, pilot testing now, sooner.
Okay, we have one more question.
The final question. HCFA created the comprehensive assessment form for the MDS. Why are the form creation costs being shifted to the home care provider for OASIS?
We're thinking about that one, and I think Kathy's going to...
I think that what you're asking is why, if I can rephrase it, why didn't HCFA develop a comprehensive assessment instrument and just hand it out to the agencies? I can tell you that the reason I was actually on a work group that was involved in making a decision as to whether that was the way to go. That work group had representatives of all the home care associations, every discipline that provides home care, and was actually convened by HCFA probably in about 1995. That decision, the decision of that particular work group was not to do that. That they felt that each individual home care agency was able to identify the essential components of a comprehensive assessment, and therefore that work group said, no, HCFA, do not develop a comprehensive assessment instrument for all of the multitude of populations that a home care agency might serve and mandate that particular instrument. So I believe that that decision had a good bit to do with the decision to move forward with requiring a comprehensive assessment, only a core group of specific data items which would be required.
How about Mary Weekland come back to the microphone? I have another question for you. Does OASIS have to be done at time of recertification?
Oh, there is a follow-up OASIS once you have completed your start of care assessment. At the time frame 57 to 62 days after the start of care, which coincides with your recert time, that's when you would complete a follow-up assessment.
Okay, thank you. Marion from Minnesota, we hope to get a question from you, but while we're waiting for you to call us back, we're going to take a question from Peggy, who's calling us from Arizona. Please go ahead, Peggy.
Hello.
Hi.
This is Peggy from Arizona, and
Yes.
I would like to have someone in that group define health services and personal care that are the exceptions for not using OASIS. Now, if you don't have specific definitions, we would be happy if you'd put it on a website.
We're going to put it on the website because you asked so nicely. Okay. Thank you. Did you have another question while you're there?
Yes.
Go ahead.
Oh, I guess she doesn't. She got it answered.
Oh, okay then.
Well, wait, I've got another question.
Well, go ahead.
Since the revised COPs will not be published for at least another year, how will you incorporate the 5 standards of comprehensive assessment requirements with the OASIS?
Ask her to say that again.
Could you, Peggy, could you repeat that question again, please?
Since the revised COPs will not be published for another year, how will you incorporate the 5 standards of the comprehensive assessment requirements? Was that not in the revised COPs?
I know what she's saying.
Tracy?
Let me just rephrase that. Or let me just give you a little bit of background on what is actually being published. Last year in March, the proposed conditions of participation for home health agencies were published. Right now at this time, we've separated out only a piece of those proposed regulations, and we're planning to publish that as a final regulation, and that would be the comprehensive assessment piece. So just that piece out of the many other conditions that were proposed last year will be published. In addition to that, and along with it at the same time, will be the reporting requirement that goes along with collecting the OASIS data. Does that answer your question?
Yes, it does.
Okay, good.
Let me add that the remaining conditions of participation will be published shortly after that, or we're expecting to publish them shortly after that.
Okay. Is that all, Peggy? All right, then. Let's take another call. We have Virgie on the line from North Carolina. Thanks for calling, Virgie.
Thank you.
Turn your volume down.
Okay. First question is, this is a follow-up question to the reassessment survey that has to be done every 57 to 62 days. There has been some confusion whether this needs to be done in conjunction with a visit, and if yes, if the physician's ordered frequency falls outside of the 57 to 62 days, will we be reimbursed for the visit, or and does the visit have to be done within the 57 to 62 days?
Mary?
The follow-up visit will need to be done within 57 to 62 days, and it has to be accompanied by a visit to the patient in his home environment. I can't address the reimbursement issues at this time, so we'll have to add that to the website.
Okay. I have another question. Is the Haven software year 2000 compliant?
Absolutely. Absolutely. I'll tell you a couple more things about Haven software since you kindly asked, and I have my cheat sheet with me anyway. You'll notice on the web page that there are draft edit specs for the software for OASIS. The draft edit specs and the draft form, OASIS B1 698, are essentially not going to change materially before publication. We had kept the draft up there in case there was some maneuvering within HCFA as it went through the processes of getting toward publication. But we have some minor changes that we are going to post next week on the website. So you will see a new version of the OASIS B1 898, and we'll pull the old one off the website. Whenever we have a change, we will post that as soon as possible on the website. And a note to software vendors, if you're waiting until publication of the reg, please don't. Please use the draft data specs that are on the web. We will have a couple minor tweaking changes that we're going to post next week. So please get started if you plan on using this software for your business. A couple of other things on the about the form. We've added a couple things that you didn't have on the OASIS B form. One thing is we put a patient's first name, middle name, and a surname if they had that. We've moved gender from the body of the form into the demographics section. We have, if you notice all the years for all the dates. The year is a 4-digit field, so we're compliant with 2000. And there's a new change in the race, ethnicity listings. We have adopted the recommendation of OMB. They had a review panel for race and ethnic standards several years ago, and they have adopted the new 5 classifications that we have used on the form. So we're in compliance with OMB, and this is the same listings that they'll be using on the 2000 census.
Okay. Virgie, I think, does that answer all your questions? Okay, Virgie's gone. Well, I have a little housekeeping duty here. If you would, please send your evaluations to the fax number that I'm going to give you, and it's going to come up on your screen. The fax number is 410-786-1008. That's 410-786-1008. Please fax your evaluations there. I believe we have Steve holding on the line from Tennessee. Steve, are you still there?
Yes, I am.
Go ahead with your question. Thanks for waiting.
For the agencies who've been using OASIS for a while, how have you found this to impact both productivity and clinical quality care?
Looks like Kathy's.
Kathy?
Yeah, I think I can address it from the standpoint of the demonstration, the agencies that have been participating in both the national and the New York State demonstrations. I think I can say without exception that all of them experienced a drop in productivity while their clinicians were first learning what the OASIS items and the amount of specificity that was involved. However, I think also they have, for the most part, experienced that returning back to what it was pre-OASIS implementation. I think there are two large variables always to keep in mind when you are talking about the impacts of OASIS on data collection in your agency. One variable is whether your clinicians are accustomed to doing a comprehensive assessment currently, and the other variable has to do with probably whether they are experienced in home care or relatively new to home care, and each agency needs to answer that question themselves individually. If your agency is accustomed to doing a comprehensive assessment at the present time, then the OASIS learning curve is probably in the range of 4 to 6 assessments, I think, as one of the providers indicated on that particular section of the videotape, and you will see after that period of time that their productivity is back to what it was before.
Okay, Steve, thanks for your question. Let's take a call from Kathy. She's calling from Cleveland. Please go ahead, Kathy.
My question is related to the fact that you have 7 days to encode, edit, and lock, which was included on our outline. Am I understanding that that means once the staff has completed the OASIS information, we then have 7 days to perform the data entry, edit the data entry that we've done, and lock it, and then we can transmit it anytime within the next month? Is that a correct understanding?
Yes, it is. You're right. You'll have 7 days to enter the data. If you have any corrections, any omissions, your data entry staff will contact the clinician to find out the correct answer. There will be edit specs. If there's a change, they will contact the clinician to make sure they have the correct information, and then they can lock it, and they can transmit that to the state agency anytime they'd like to. If they want to do it on a monthly basis, they can do that. If they want to transmit it more frequently than monthly, they can do that.
Okay. Any other questions, Kathy?
Yes, actually, you had mentioned before that you had a I thought I understood you had a choice to not integrate the form, but if that you were using your assessment and the OASIS in separate actual instruments during the assessment visit, that you would need to eliminate any information on your assessment instrument that was also included in the OASIS. Is that correct?
Yes, that's correct.
Okay, Janice?
Yes, you are to look at the two forms, your form and the OASIS, and anything that is on the OASIS that also appears on your assessment, you remove your items. In other words, you replace your items with the OASIS item.
Okay. Kathy, thank you so much. Let's take another call.
We are a small to medium-sized agency that does over 90% of our cases in extended hours visit cases that are 24-hour, for the most part, dependent patients with degenerative disorders. And basically, for outcome, you know, what we judge is if we're going to be able to minimize their hospitalizations and keep them maintained at the current level they're at with preventing further contracturing. How does OASIS affect us?
All right, who's going to take that? Kathy?
Mary Vienna had to leave and I think left me in charge of and I hope I answered this question correctly. I think, again, if you are a certified agency, Mary said that the OASIS data collection was required for all patients of the certified agency. If you're asking whether the outcome measures that are possible to compute from OASIS would apply to those patients who are part of your agency, I can tell you that the answer to that question is yes, because there are many patients like yours in other agencies across the country where, in essence, the purpose of your care is really to make sure that that patient condition stabilizes. And indeed, some of the outcome measures that are computed from the OASIS do indeed look at the stabilization of, for example, functional ability.
Okay. Thank you very much, Karen, for your question. Just one quick reminder again, before our program is over, we'd ask you to send your evaluations to us by fax. And that number again is 410-786-1008. We have Jochebed calling from Maryland. Please go ahead, Jochebed, with your question.
Yes, I need to hear again about the 60-day research between 57 days and 62 days. If you have patients who you're visiting once a month, should you plan to see that patient when it's time to research? You plan to see that patient within maybe 25 days so that you could be within the 62 days?
It is important to plan the visit schedule accordingly so that that visit does indeed fall within the 57 to 62 day time frame. We have found that many agencies, most agencies, really are able to do this and to associate that data collection, that assessment data collection, with the recertification. In fact, I am a great advocate of integrating the OASIS data collection into all of the other components that are required for your agency, not to make it something that's separate, but rather to make it part of your routine in terms of care delivery. And this is exactly what we have seen agencies do. They have made sure that they have a visit timed between that day 57 and day 62 of the certification period. They have used the patient's status at that particular time as the basis for the recertification, or if no recertification is indicated, then that OASIS data collection actually becomes the discharge assessment for that patient.
Thank you very much, Jochebed, for your question. Just a reminder to the callers who had questions, but we didn't have the answers at this very moment. Do me a favor and put those questions in writing, and then put them on the OASIS mailbox on the web page, and we will be sure to get back to you. And I still have a stack here, but because of time we won't be able to answer them all, but you will get answers to your questions. So again, if you called and asked a question we didn't have the answer, put it in writing and send it to the OASIS mailbox, and you will get an answer. Everybody okay? All right. Well, this concludes our broadcast. I hope that it was helpful and informative, and it will help you in getting started with OASIS. I'd like to thank all of our panel members and you, our viewing audience, for participating in this important and informative broadcast. I'm Doris McMillan. Good day.